Partha has not joined.
Let me, can I start?
Yes. So good morning and warm welcome to Online Anaesthesia, a postgraduate teaching program on Zoom platform, sponsored by Acrola and hosted by 8May2022. This is the first time it is going to be aired by the Anaesthesia TV also. Today we have two topics for first year postgraduates and a video demo on echo. It is useful for the practitioners also. So the first topic is Anatomy and Physiology of Pain by Dr. Partha Sarathy. He is working as a professor in Mahatma Gandhi Medical College Research Institute and Puducherry. His academic achievements are innumerable. Difficult to enumerate everything here. He has presented around 145 research papers in reputed journals with 475 citations. And he is the associate editor of Indian Journal of Anaesthesia. And he has created his own website, Pain Free Partha, for the benefits of the postgraduates. And he is conducting Friday Anesthesia Continuing Education via Zoom as a Fridays at every Friday 6 p.m. And he received many awards and he released 8 Tamil poetry books and he is a great Tamil scholar too. So over to Professor Partha Sarathy. You can play the videos. Shilpa. So it's not playing.
1 second, sir.
Whenever I talk anything on academics, I put a big salute to the legendary teacher of 2 centuries, Professor Ravi Shankar, who is currently the director of e-learning in MGMCRI. So what is my talk is going to go about like definition, pathway, taxonomy, some pathological terms and meanings, the descending control of pain, and practice spells linking physiology, anatomy, and pharmacology. What is the definition of pain? So little older definition, but it is staying still. An unpleasant sensory and emotional experience. See, here it's not only a sensory, it's an emotional experience. It is unpleasant. It is associated with actual or potential tissue damage. Actual damage or potential tissue damage. It cannot be two also, described in terms of such damage. So it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Some say an unpleasant sensation occurring in varying degrees of severity as a consequence of injury, disease, or emotion. Pain has always got a subjective component. So this is Professor M.R. Rajagopal. He says pain is something which hurts. So what is nociception? What I understood is nociception is activation of a nociceptor, a potentially tissue damage, the noxious stimulus. It is the first step in the pathway. Some damage is done, and probably I think the emotional or the affective component is not there. It's a sensory component which makes no detection. For example, rat tail clamp. That is a form of nociception. A nociceptor is a specialized neurological receptor capable of differentiating between noxious and noxious stimulus. What we have is A delta and C fibers. Now, how is pain perceived? Now, we know A delta fibers and C fibers. This is myelinated, this is unmyelinated. So, this is diameter we can see here. This is myelinated yes and unmyelinated yes. This is for first pain and this is for the second pain. So pain starts by the nociceptors here, and then it travels along from the A delta C fibers to the dorsal horn, and from there it synapses in the second order neurons of substantia gelatinosa, and from there it ascends contralaterally, other side, and goes in this side, and it reaches the thalamus, spinothalamic tract, and from there the thalamocortical projections. Yes. Posterolateral nucleus of the thalamus. Paleo-spinothalamic neurons known as the C fibers. Neo அப்படிங்கிறது more of A delta fibers. From the thalamus, the third order neurons to the cortex. And the cortex, we can have anterior cingulate cortex, the emotional aspect, and the somatosensory cortex is the actual noxious, painful sensory cortex. Now, that is also the second order neurons. From here, this is the first noxious stimulus. From there, the first order neurons, synapse here, the spinothalamic tract goes above. From this, the third order neurons, the thalamocortical projection system in the cingulate cortex and the somatosensory cortex. But it is not the only thing. Sometimes we can have spino-mesencephalic. Mesencephalic, the midbrain. So behavioral responses to pain. Spino-reticular system, reticular formation, motivational aspects. All these things are also there. So from there, first, from the dorsal horn, first order neurons, lateral spinothalamic tract, thalamus, and the cortex. Also, we have spino-reticular and spino-mesencephalic. As I'm again telling you, this is the pathway of first order neurons, the second order neurons, and the third order neurons. So, this is the basic anatomy of pain. So, we will go to what are some specific terms associated with pain. Patient has no pain, but he has got the noxious stimulus. That is what is called analgesia. Patient has pain, but there is no painful stimulus. Then it is not called analgesia. Anesthesia means all sensory modalities are gone, while analgesia means only pain is gone. Paresthesia means abnormal sensation. Either it may be spontaneous or evoke. We can evoke a paresthesia, or it may come as an abnormal sensation in paresthesia. It may be either painful or painless. Painful paresthesia is sometimes called dysesthesia. Formification, leave out this. Now we have one more term called anesthesia dolorosa. Anesthesia in all sensory modalities are gone. Dolorosa pain. All sensory nerve is gone. Still we have pain in that area. That is what is called anesthesia dolorosa. You just ablate the trigeminal nerve. There is no sensation. If you touch, we cannot feel. But this, the neuralgic shooting pain comes. This is called anesthesia dolorosa. Hyperpathia refers to an abnormally intense response to a repetitive stimulus. Algogens, algona, algesia na pain, analgesia na pain relief. Algogens na pain generators. What are these pain generators? Histamines, substance B, potassium, prostaglandins, bradykinins, serotonins, etc. When injected also it produces no. So what is hyperalgesia? Now you have a stimulus. This is the normal pain response. If the pain response is more, then it is called hyperalgesia. So shift it to the left and not right. So shift it to the left. Pain to a non-noxious stimulus in the injury. Sometimes pharyngitis, swallowing painful. That is called allodynia, non-noxious stimulus. So there is something called primary hyperalgesia and secondary hyperalgesia. It starts within minutes on the area of injury. This is due to peripheral sensitization. Peripheral nerves, nociceptor, there is some change. So small pain stimulus, big pain is sensed. That is sensitization. So secondary, delayed onset, wider area, only thermal stimulus, and there may be a central. Primary hyperalgesia, there are so many mechanisms. Camp levels and PKCs have been explained. Antidromic release of algogens. Dorsal horn neurons become sensitive. Wide dynamic neurons. WDR neurons. There are some plastic changes. Sometimes they are irreversible. Now, what is sensitization? We all told hyperalgesia is due to sensitization. If the stimulus pain is more means the shift to the curve is left. Then it is called hyperalgesia. The fiber response is more, then it is called sensitization. This is more of an electrical sensitization. That is more of a clinical hyperalgesia. So it means a peripheral receptor or a central response, more intense fashion. So it can occur in the nociceptor in the periphery, or it can occur in the spinal cord. So this is about the various terms what we have. Hyperalgesia, hyperpathia, allodynia, anaesthesia dolorosa, sensitization, so many terms. Allodynia means there is no painful stimulus. Touch patient pain. So these are all some of the terms. Now we go to classify. Why do we need to classify the pain? We need to understand the where from it has come from and the treatment modalities. From there we can judge the prognosis. So if you want to go as a temporal classification, acute, just you have a trauma, elbow injury, knee injury, it's an acute pain, acute gastritis. Chronic means it persists for more than 3 months. For example, the patient has got an intercostal neuralgia, post-herpetic neuralgia. Recurrent means duodenal ulcer. There are other classifications according to the etiology, according to the site. Nama first classification according to the temporal, time-based, acute, sometimes subacute, around 3 weeks. More than 3 months is chronic. Now we have a classification depending upon the etiology. It's an arthritic, a malignant pain. Where is the pain like? From the appendix, from the breast. This is one type of taxon. What is more important is whether it is a nociceptive pain or a non-nociceptive pain. Nociceptive and noxious stimulus is there. Somatic nociception. If you have a trauma, injury, if you have some paronychia, pus in the nail bed, that is somatic nociceptive. Visceral means there is appendicitis. Non-nociceptive is neuropathic, central, and psychogenic. There is no noxious stimulus. Nociceptive somatic, yes, we know toothache. Very simple example. It increases with movements, dull or sharp, localized. Now we can have so many examples of nociceptive somatic pain. Yes, visceral nociception, renal pain, appendix pain, autonomic sensations will be there, nausea, vomiting, sweating, especially with visceral nociception. Neuropathic means yes, burning, electrical, sometimes numbing. The intervening period is normal. Suddenly, just a burning sensation for half an hour, then it becomes normal. Intervening period is normal. That is not there with nociceptive stimulus. Sudden, postherpetic, trigeminal, glossopharyngeal, neural. Yes. Now we have central pain syndrome is a neurological condition. But tumor, stroke, Parkinson's disease. This side stroke means they will have complete pain. Continuously they will have pain. This is very difficult to treat. There are a lot of theories which have been proposed for this neuropathic pain. Specific cellular and molecular changes that affect membrane excitability. New gene expression after nerve injury. So many things. For example, ectopic impulses of neuroma, changes of sodium calcium channels. So many things have been proposed for neuropathic pain. Psychogenic pain. What we have now is nociceptive, somatic, visceral. Non-nociceptive, peripheral or neuropathic, central, post-traumatic pain, stroke pain, all these things. Psychogenic pain means they are mental, emotional, behavioral factors. Headache, backache, some of the common causes of psychogenic pain. Eurosocial rejection, emotional event, grief, all these things will be there, but there is no nociception, no neuropathic mechanism. So these are never acute. Psychogenic pain is usually chronic. So what are the so many theories of pain have been come? So Aristotle believed that pain was due to evil spirits entering the body. It was due to an imbalance in vital fluids. It was thought as a punishment from God. So is a disturbance which passed along to the brain. So specificity theory. Body has got a separate sensory system for perceiving pain. The hearing ko or sensory system, vision ko or sensory system. Pain is separate sensory system. This is what is the first thing we started, that there is something separate for the pain. Pattern theory. He said there is no special sensory. If there is a pattern difference, something called, if we have touch or pattern of sensation. Pain there is some pattern. This is what is called pattern. Intensivity theory, if you slightly touch, it will be touch. Touch it hard, it will be seen as pain. That is what is called the intensity. We will go to Melzack-Wall gate control theory. Pain stimulation is carried by small slow fibers, which already we have done. A delta. We are not targeting A alpha or anything. Specific nerve fibers, yes, okay. Now, the small fiber here, pain is going, transmission, patient is having pain. Now, there is one gate. This is inhibited by this. This further inhibits so that the pain is more. But if large fiber is stimulated, this closes the gate and substantia gelatinosa is stimulated so that the transmission is decreased. This is what is called as the gate control theory of Melzack-Wall. So the gate opens and closes. This is what is the thing. If the large fibers remain unstimulated, large fiber we have not stimulated, pain signal will be continuously thing, and so that the patient will have pain. Now see here, there is a pain, headache. It is going on, patient is having a headache. Now we put some balm. We are stimulating the large fiber. This large fiber is stimulating the substantia gelatinosa plus, and the substantia gelatinosa is inhibiting. So SG acts as a gate to decrease the pain by just pushing as Zandu balm. So now we have one more thing. patient itch and pain the same fiber. Now we have got itching, and now what we do is scratching. Now by scratching we decrease itching. We are not doing anything on histamine or anything like that. We are stimulating the large diameter fibers plus substantia gelatonosa. The simple example of gate control theory. So what is the neuromatrix? How does it work? So there are a lot of things which cannot be explained by the gate control theory. So the neuromatrix consists of multiple areas within the central nervous system, brain thalamus, limbic system, prefrontal areas, spinal cord, etc. They work together to produce a pain signature. This is what makes one to feel pain. This is what is called the neuromatrix theory. Only peripheral signals cannot elicit pain signature. So it has to be the impulse causing a work together of all these things. Limbic system, another affective component, because otherwise only sensory component. So all these things is what is called the neuro signature. Now this is biosocial psychological theory or biological factor. For example, tissue health. Or social factor, economic status, social learning, social support. Or psychological factor, catastrophic thinking, hypervigilance, depression, anxiety, anger. Bio-socio-psychological model of pain. So for example, now we have a wound. This wound is causing pain and a neuropathy is there. This also causes pain. This is biological. This is followed by patient is a depression and mental agony. This is psychological. Now or he or she will be treated as a social outcast where in HIV. So bio, psycho, social, all these factors play a part in HIV. This is what is called biosocial psychological model of pain. Now we will go to the descending influence. What is this descending control? Now we know from the nociceptor, prostaglandins, histamines, algogens are stimulated. It stimulates the peripheral nerves. It goes through the dorsal horn, lateral, all these things we know. This is what is called the ascending pathway of pain. Something called the descending control. We have rostromedial nucleus, periaqueductal gray, the dorsal root ganglion, cortex. From there are a lot of things which passes into the DRG. This is what is called the descending control. Pain modulation, in particular, the inhibitory modulation, what is called the endogenous analgesia. ஒரு pain stimulate பண்ணும்போது descending control வந்து கொஞ்சம் pain decrease. This is what is called pain inhibiting pain. From where the modulation? Thalamus, hypothalamus, brainstem. There are 2-3 things. Locus ceruleus. Here you can see the locus ceruleus. Nucleus raphe magnus. Here is NRM. Nucleus tractus solitarius, here it is. Periaqueductal gray, here it is. So these are all the sites of possible areas or sites of descending modulation. How we came to know that there is something like that? For part of the brain, if you give stimulation, then it causes analgesia. Brainstem stimulation causes analgesia. If you stimulate a brainstem nucleus, it influences the dorsal horn to decrease pain. That is how we found out that there is something called descending control of pain. So normally opioids, noradrenaline, serotonin is involved, but now they have found out even GABA is involved. Modulation means inhibition and also sometimes facilitation by the way of glutamate. What I want to specify descending control is an exam question. Periaqueductal gray, opioids. Okay, locus ceruleus, noradrenaline. This is serotonin, nucleus raphe magnus. The prime chemical, periaqueductal gray, opioids. This is norepinephrine in locus ceruleus. Raphe magnus, NRS, nucleus raphe magnus. Midbrain, pons, and this forms the brainstem. So ONS, PLR, opium, noradrenaline, serotonin. Periaqueductal gray, locus coeruleus, and nucleus raffimagnus. There is also something called descending modulation of pain, the GABA. Yes, that increases GABA and decreases pain. It is also there in the descending modulation. Synthetic, non-synthetic cannabinoid drugs, they also influence the PAG and also the RVM neurons, thereby control the descending modulation. TRPV1 receptors, transient receptor potential vanilla type 1 and vanilloids. This is where our capsaicin works. Capsaicin, if you do like this, so it causes a burning sensation and it depletes substance P, thereby causing analgesia. So this is one of the causes of descending. Great paracetamol, they also say there is something periaqueductal gray. It stimulates the role of opioids in the bag. So it also stimulates GABA. All these things have been found out with paracetamol. This is my article, effect of addition of intrathecal midazolam. So spinal and supraspinal midazolam. It potentiates morphine-induced and agent-induced analgesia. GABA mimetic midazolam action. But spinal it potentiates morphine. That is opioid like it has got influence. Opioids stimulate PAG that we know. Periaqueductal gray opioids. There is also a GABAergic pathway. Yes, contribution of pain in opioid tolerance. There is a small difference in tramadol because it also acts on the mu receptor and it also acts on the monoamine reuptake, serotonin, norepinephrine. Thereby, the descending pain is modulated. Yes, we all think that clonidine, release of norepinephrine, descending bulbospinal neurons, binds to the alpha receptor. Sympathetic outflow is decreased. That is when you give IV or IM. What does it do when we give? It increases the action of opioids. It causes vasoconstriction. This is more of an action when we give clonidine into the spinal, while we give parenterally, it is alpha 2 receptor decreased afferent pain. What we thought was TENS, transcutaneous electrical nerve stimulation. If you keep the TENS paddles here and if you give a stimulation, it is likely to work like a gate control theory and causes pain relief. Now they say this pain relief is also due to a descending because contralateral stimulation. If you stimulate the left hand, there is a decrease in pain in the left hand. Right hand, how does it possible? So if you are going only by the gate control theory, there is some GABA changes, there is some enkephalin changes. Electroacupuncture. It has been demonstrated that electroacupuncture also we thought it is gate control theory. No, it has got some action on nucleus raffimagnus, 5-HT serotonin, and also in locus coeruleus as descending systems. Previously, it was thought as only ascending systems. We have gotten, this is our article, post-stroke pain with acupuncture. Chronic primary pain is a group of diseases with long-term pain and functional disorders. Without seeing fibromyalgia, temporomandibular disorders, this duloxetine venlafaxine, they have got increased serotonin level in the prefrontal cortex and thereby they influence control of pain. Yes, they have now found out chronification of pain. Acute pain becomes chronic. I will take in one more class how they transform acute pain into chronic pain. Transition, how does it occur? That's a completely different topic. Descending pain modulation. If you want to go in a psychogenic angle, disruption of endogenous pain modulation by chronic pain alters cognitive and emotional processing. Yes, we thought all these things are due to spine and mesoencephalic tracts, causing what they say is a neural signature, neuromatrix involving the limbic system. But now they say even in the psychogenic pain, there is a role of descending modulation. Dysfunction of the central inhibition of pain has been influenced as chronic pain. But we think otherwise. There are a lot of manual theories, and we know descending modulation in so many manual theories. Manual manipulative theory, knee joint manipulation, ankle joint mobilization, all these things previously we thought ascending only, but now they have got role in descending control. Micro, see, non-steroidal anti-inflammatory drugs, brufen, diclofenac are supposed to act periphery on the pain side, but now they have said micro injections in the periaqueductal produces, they release endogenous opioids. Some NSAIDs, do they have a role in descending pain? Now we go to clinical dimensions. Why should acute pain produce a sympathetic response? BP raise a boom, but fate raise a chronic pain does not. Now I have a ascending and descending modulation system. It is quite not, it's a roughly drawn, I'd say. If a site of pain, here there is an injury. From here it goes, crosses and goes above and here, and there is a descending modulation. Now if this is a site of pain, injury, now we can give local anesthetic here. Or we can give NSAIDs parenterally. So that prostaglandins and other algogens stimulation is decreased. Now it goes through the dorsal nerve, dorsal root ganglion, enters the spinal cord. Here we can give a block. And then it goes to the ascending pathways. We can have neuroaxial, epidural, spinal. We can have, yes, here we can have alpha-2 receptors and clonidine. In the pack, we can have opioids. It also acts in the descending modulation system. Clonidine acts here also and here also. Duloxetine, it cuts the neuro. We have already told. There are some wide dynamic rodents. There is a role of 5-HT in the descending modulation. So duloxetine can cause decreased neuropathic pain and also descending modulation of pain is affected. Paracetamol is centrally acting and also some role in periaqueductal cleaning. Ketamine, where is this act? Thalamocortical projection system. That is where it cuts down the NMDA. Psychological, as I have told, anterior cingulate cortex, where we can change. So this is about a simple diagram of how many drugs compete and act in many places of the ascending and the descending path of pain. So if you want to do a summary, as definition, it's an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Classification will be acute, subacute and chronic, or where is it? Arthritic or malignant or appendix or anything like that, or nociceptive or non-nociceptive. Nociceptive, there is somatic and visceral. Non-nociceptive, there is neuropathic, central and psychiatric. In the theories, first is a specificity theory, intensity theory, pattern theory, gate control theory, neuromatrix theory, and biopsychosocial theories. We all know the descending influence from the PAG, opioids, periaqueductal gray, locus ceruleus, and nucleus raphe magnus, the role of noradrenaline and serotonin. As I've already drawn a diagram to tell what are the clinical pearls are targeting drug therapy in very simple terms. There are so much in pain therapy, I'm not going into newer analgesics. So are we ascending too much? Can we descend slightly, look down and look into these sectors?
Sir, you are in mute, sir.
So thank you very much, Pastor sir. We will move on to the second topic. If there is any questions, we will take up the questions in the end of the session. So the second topic is the pharmacology of opioids by Dr. Sivaprasad. He is working as the assistant professor in the Institute of Anesthesiology, Madurai Medical College. He is one of the pillars of our online anesthesia. His lectures are very popular among the postgraduates. His field of interest is cardiac anesthesia and teaching basics for the postgraduates. Over to you, Mr. Prasad, sir.
Thank you very much, sir. Thank you for the introduction. Good morning, all. And after hearing some good lecture on pain, I think we have to start with the analgesic also. So thank you for this topic. I'll tell you why I have put this myotic pupil in this picture in the last slide if there is time. As Thomas Sydenham rightly told, among the remedies which has pleased Almighty to give man to relieve his suffering, none is so universal and so efficacious as opium. So from the day of opium being used as an analgesic till today, it has been very useful and also been more abused. So into what are we going to learn today? As usual, we'll slightly give credit to our contributors in this analgesic field. Then we'll learn few things about structure of opioids so that we remember how they are classified based on the source and structure. We'll also look on how opioid receptors behave when they are bound with the ligand so that we can understand how the classification is based on activity on receptors. We also look into the pharmacodynamics so that we understand the structure and activity of the mu agonists, pharmacokinetics on how we choose these drugs, and pharmacology of commonly used. See, I'm not going to talk about all the drugs because you will go into narcosis. We'll look into the pharmacology of some commonly used but less read drugs. And additionally, if I have time, I'll cover novel delivery systems in the opioids, genetic variation and how this opioids affects varies among individuals, and a new field of interest called biased agonism. So let us move on to the topic. So it was in 3rd century BC. Look at the time, it is very, very old. Theophrastus writings had uses of opium. And in olden days, more than its analgesic property, they were used as antidiarrheals. It was in 1600, Paracelsus, he has produced this tincture of laudanum, which contained mixture of alkaloids which relieved pain. And in 1680, Thomas Sydenham purified this laudanum and used its extract as an analgesic proper. It was in 1806, Sertner, a pharmacist, isolated morphine from opium. This is the starting point of the active pharmacology of the opium alkaloids. And in 1874, heroin was the first synthetic opioid to be synthesized. Here I have to tell about somebody called Beecher in Lucknow. He was a military man. He observed that people behave differently in the when they are wounded in the war field than in the clinical settings. So he described the neurohumoral relationship of the opioids, and in the later years in 1970s, he described the agonist-antagonist activity of opioids, and he discovered nalorphine. It is from that the agonist-antagonist activity and the search for different type of opioid receptors started developing. Martin et al., they described the opioid receptors, the mu, kappa, and delta, and now it is IUPAC name is given as MOR, KOR, and DOR. And the endogenous analgesic peptides were illustrated in 1975, and latest is in 2006, biased agonism, and looking for drugs that have very, very specific effect, that is analgesia without any side effect is being developed. So these opioid chemicals are derived from poppy plant, it is Papaver somnifera. The resin contains a lot of alkaloids. They are morphine, codeine, and thebaine. So opiates refer to that which are derived from these alkaloids, and opioids means any chemical that has activity on the opioid receptor. It could be endogenous opioid, which are peptides, natural opioids, that is morphine and its derivatives, or synthetic opioids, which we are developing today. So coming to the structure of opioids, so all these chemicals are derived from a basic backbone nucleus called the phenanthrene molecule. It is a 16 carbon atom molecule with a 5-ring structure. You can see the 5 rings here. And this is a optically active chiral molecule, means it has an levorotatory form and a dextrorotatory form. In nature, all these compounds come in an active levorotatory form. Dextrorotatory form is not there. and it's not useful also. And you can see here, there are some targets of substitution. The hydroxyl group on the two ends, the keto group and the methyl and the hydrogen group are all target substitution, so that we can produce newer compounds with better pharmacological profile. Look at this, the first benzene ring and the third one. These two together are called the phenylpiperidine nucleus, from which the newer agents, the fentanyl, the sufentanil, everything are developed from this 1 and 3 nucleus alone. So this is the morphine molecule, the phenanthrin molecule. If you can change the hydroxyl molecule here into a keto group, you get oxymorphone. If you change it to a methyl group and this hydroxyl, you get codeine. If you combine these two, you get oxycodone. And if you put two acetyl groups on these hydroxyl molecules, you get heroin. So all this classification is developed because of this backbone phenanthrin nucleus. Even the antagonist, naloxone and naltrexone, are phenanthrin molecules basically, with aryl and allyl substitution in the nitrogen atom, so that they can act as an antagonist. Coming to the phenylpiperidine nucleus, see, you can already told you this 1 and 3 rings will provide the backbone. This is the benzene structure with the nitrogen attached. On one side there's a methyl, and the other side you have a allyl nucleus. So this is the basic structure of pethidine. Pethidine is a fully synthetic compound, out of which many other compounds have been developed. See, if you substitute this methyl with the anilopyridine, you get fentanyl. If you put a sulfur nuclear atom in this, it will become more and more lipid soluble and become sufentanil. If you can add an oxy group here, it becomes alphentanil. It gives a typically different properties to it. And if you add two ester groups here, which are susceptible to action by esterases and quick termination of action, it is called remifentanil. Now I'm going to put, and these all are together called anilidopyridines. See, I have put another chemical structure here, which has a nitrogen atom here, a methyl group like the same pethidine, and a side chain. Can someone, anyone of you identify what this molecule is, so that you can understand some of the physical properties of physiological properties of pethidine? You can put that in the chat box. This molecule, you can identify what it is. So based on classification based on source and chemical structure, we have natural, semi-synthetic and synthetic compounds. Natural are again divided into phenanthrin, as we saw, phenanthrin and benzyl isoquinoline derivatives. Benzyl isoquinoline derivatives are not analgesics. They are used as either smooth muscle relaxants or antitussives. Under phenanthrin, we have the natural ones, morphine, codeine, and thebaine. The semi-synthetic derivatives are all derivatives of either morphine, codeine, or thebaine. So from morphine, we can get heroin or dihydromorphone. The codeine analogs, they are not codeine derivatives, but they are codeine analogs. They are tramadol and tapentadol. The thebaine derivatives are etorphine and the buprenorphine. The antagonists are naloxone and naltrexone. So it is easy, right? So if you can remember the phenanthrin molecule, you can derive the semi-synthetic molecules also. Coming to synthetic, so as we also already seen, we have phenylpiperidine derivatives, that is pethidine, fentanyl, sufentanil, remifentanil. These morphinol derivatives are levorphenol and butorphenol. Benzomorphone derivatives are pentazocine and phenazocine. Diphenyl propylamine derivatives are methadone and propoxyphene. You have to by heart these synthetic group only. Semi-synthetic, you can easily remember and write in the exam. Coming to the opioid receptor is a rhodopsin family G protein coupled receptor that is present in the cell membranes. So when a opioid binds to it, what happens is it activates a G protein inside the intracellular component. The first thing what happens is it opens a potassium channel, which is inwardly rectifying. Inwardly rectifying means what it is. Whatever potassium can either move inward or outward, it will hyperpolarize the membrane. On the other side, it also will inhibit the voltage dependent calcium channel in the presynaptic membrane. So calcium entry is prevented. This is the main action of an opioid receptor. Once the opioid binds to it, it will either modify the potassium channel in the postsynaptic membrane or close the calcium channel in the presynaptic membrane. Other effects are, it will also inhibit the adenyl cyclase, leading to decrease in cyclic AMP and MAP kinase pathway, which lead to tolerance. So this is the basic structure of an opioid receptor, which is a 7 transmembrane spanning protein, which is a G protein coupled receptor. So coming to the presynaptic and postsynaptic effects. So this is a neuron. It might be a first order neuron, and this in a postsynaptic one would be a second order neuron. When a pain stimulus comes to in this first order neuron, what happens is pain transmitting substances like glutamate, substance P, and CG reactive peptide will be secreted. All this will go to the post receptor and stimulate NMDA, AMPA, neurokinin receptors and produce acute and long-term pain. What happens is once the opiate receptor is activated here, it will prevent the calcium conductance into this presynaptic neuron and reduce the secretion of glutamate and substance P. Postsynaptically, it will hyperpolarize the membrane and it will reduce the activity of NMDA and AMPA and neurokinin receptors, thereby modulating the pain. So the opiate analgesic is not an absolute anesthesia, but it's a modulation of pain. This, depending upon the cloning of opiate receptors, they are divided into mu, kappa, and delta. Mu is again classified into mu1 and mu2, depending on what effects it predominates in them. So all these receptors have analgesic component. Mu2 has only spinal component, whereas all others have supraspinal component also. I'll talk about what is supraspinal component in the next slide. And the main side effect of mu2 is depression of ventilation, and kappa is dysphoria, whereas mu1 produces euphoria. Mu2 also has physical dependence potential. So as you can all see from this, stimulating mu1 is beneficial and mu2 is not so beneficial. And all these receptors produces some amount of meiosis, and constipation is markedly produced with mu2 receptor. There is also a diuretic potential for kappa. As we can, when we go ahead, we will see this kappa agonists. So they all produce some amount of diuresis. When you look at these receptors, they are always in a heterodimeric state. That is, mu receptors will be closely associated with kappa receptors. They will be in one complex. That is called heterodimerization. So the next classification is depending on how these heterodimerization helps us. So when you talk about a pure agonist, it is always the mu receptor and kappa receptor which stays together. So all these binding agonists, morphine, pethidine, they have potential to stimulate alpha and kappa receptors equally. When it comes to partial agonists, they act on mu receptors specifically and they block the kappa receptors. You can see here, it's only half a molecule high, like how we have heparin and low molecular heparin. This is only half a molecule. It will prevent binding of other substances into the kappa receptor, and it will act only as a pure mu receptor, and that is why it has got less than effect of the pure morphine. Coming to agonist antagonist class of drugs, they will stimulate the kappa receptor specifically and block the mu receptor. So they have got a different type of pharmacological profile. When it comes to antagonists, they block both mu and kappa receptors. So we'll start classifying their drugs from antagonists so that it's easy for us. The pure antagonists are naloxone, naltrexone, and their derivatives methylnaltrexone, nalmefene, naloxegol, and albumin. Remember, naloxone and naltrexone are distributed throughout the body, whereas methylnaltrexone, naloxegol, and albumin are peripherally acting antagonists. Coming to agonist antagonist, we have nalbuphine, butorphanol, and pentazocine. These three drugs are the named drugs of this class. And the nalorphine was the first drug which was discovered, but it's not in use now. Desazocine is another drug which is commonly used in China, but not here. You will have to remember the three drugs, nalbuphine, butorphanol, and pentazocine for its effects. The only drug which we have as a partial agonist is buprenorphine. It binds only to the mu receptor and prevents any other kappa agonist binding to the kappa receptor. The pure agonist, now we can write everything else is pure agonist. Morphine, pethidine, fentanyl, tramadol, methadone, all our others are pure agonist. One drug which I want to tell about is meptazinol. This drug, we already saw mu1, mu2. Mu2 has all derogatory effects and mu1 has beneficial effects. Meptazinol is a specific mu1 agonist. They are trying to develop mu1 specific agonist. Though meptazinol has all beneficial effects, it has also got side effects also. Coming to pharmacodynamics. other than that, its original effect, opiates have got variety of effects on the whole body because the opioid receptors are widely distributed. So it has got too many effects. So you'll have to manage many things other than analgesia also. Coming to the prime effect, analgesia, it is described as modulation of conduction and modification of perception. It occurs at 3 levels. The first level is peripheral opioid receptors. It has been a recent discovery of the existence of peripheral opioid receptors. They have 2 functions. One is it modifies the pain transmission. The second is it also promotes wound healing. If you have pain, there is antidromic conduction of wound healing substances that come through back to the first order neurons and increase the wound healing. So giving morphine into a knee joint or injecting in as an infiltration, all these act through peripheral opioid receptors. Coming to spinal effect, it is mediated in the level of substantia gelatinosa, as we already saw. The first order neuron, when it goes and synapses the second order neuron, there is a presynaptic and postsynaptic modulation that occurs at the spinal level. Coming to the supraspinal level, the main area that modulates this is called the periaqueductal gray matter. So all these analgesic effects are more effective in a second pain. That first pain means the cutting pain, which is conducted through A delta fibers. The second pain is the deep, slow pain, which is modulated through the C fibers. Opiates are very effective in abolishing the second pain. And the particular specialty is that the touch, the temperature perception, all these are not affected. Only sensory modalities are affected. Coming to the supraspinal mechanism, we have in this picture, we have a first order neuron synapsing at the level of the spinal cord. From this, different type of, that the perception goes through spinothalamic tract. But here we have another parallel track running. It is called the ascending spino-mesencephalic tract, which synapses at the medulla, pons, and midbrain. It straight goes to the midbrain where it activates the periaqueductal gray matter. In that place, periaqueductal gray matter relays through enkephalogenic neurons, which will inhibit the GABA neurons, which are tonically active in inhibiting the glutamate neurons, which descend down. So once this glutaminergic neurons from the midbrain to middle are activated, they activate some places called Raphe Magnus neurons, which again descend down to the same place where everything started. So this rostral ventral medulla will again activate spinal encephalogenic neurons. Here the enkephalins are secreted and they act presynaptically and postsynaptically. So it is a loop from the pain. The pain pathway ascends one through the spinothalamic tract, the other the spinal mesencephalic tract. It activates the periaqueductal gray matter. From there, it descends down through the rostral ventral medulla to the spinal cord, secreting enkephalins, which will modulate or decrease the pain perception. This is how the supraspinal mechanisms are affected. So how will you measure this analysis? Like we have BIS monitor or EEG-based monitors to monitor the effects of anesthetic agents. We don't have any effective monitor for measurement of analgesia. There are 2 measures. One is the max sparing effect in the intraoperative period. That is, you can lower down the usage of inhaled anesthetics if you use high amount of opiates. That is called the max sparing effect. The other one is physiological parameters, the tachycardia, hypertension, sweating. With all this, you can measure. But do we have an objective measure of analgesia? Yes, we are developing a monitor called the Analgesia Nociception Index Monitor. The input for this is the heart rate variability. Suppose you give an incision and there should be tachycardia. If you can keep the tachycardia less, and the respiratory, they also say that the opioids reduce the respiratory changes in the RR intervals. So with this, they are monitoring the amount of analgesia that is given with the opioid. This is called Analgesia Nociception Index. The range should be between 50 to 70. So you can see here it is a slightly higher value which is seen here. So this monitor is the upcoming monitor. Soon we'll also have like a BIS monitor, we'll have an ANI monitor. Coming to the next one, sedation. It is because of the reduced acetylcholine output from the prefrontal cortex in the basal forebrain. That is why patients become drowsy after the opioids. But loss of consciousness can occur only at very high doses. But this loss of consciousness is unpredictable and inconsistent. Not everybody becomes very drowsy because of this opioids. Though it has got max sparing effects, burst suppression never occurs, and these drugs should never be used as sole anesthetic agents for reducing the consciousness. Coming to euphoria, that occurs at the nucleus accumbens level. So nucleus accumbens is under tonic control of the ventral tegmen areas with dopaminergic neurons. The opioids act both presynaptically and postsynaptically, reducing the dopamine on the nucleus accumbens and produce rewarding properties that help. That also has got a negative effect on us, that patients become more dependent and tolerant on opioids. Pruritus is a very irritating thing which is yet to be conquered. So it occurs through histamine release in case of morphine. It also occurs because of trigeminal nucleus stimulation and also because of peripheral opioid receptor activation, because different mechanisms are there. One specific drug to prevent pruritus is not there. They have discovered many areas where these opiates act and produce pruritus. Coming to management of pruritus, the most effective one is ondansetron, and especially in case of patients who have pruritus with neuraxial opioids, opiate agonist antagonists like pentazocine, nalbuphine, and these drugs also can prevent the pruritus. And now research is into peripherally acting antagonists which can reverse these effects. Naloxone also can reduce pruritus, but the problem is it will reduce analgesia also. Coming to muscle rigidity, we are all aware that when we give fentanyl, we are afraid of this woody chest. So this is because of stimulation of mu receptors in the striatum. They increase the dopamine levels and decrease GABA, like how it occurs in cases of Parkinsonism. So because of this, patients will have woody chest, a lead pipe trunk, and adducted vocal cord. So you will find it very difficult to ventilate when you give. So this muscle rigidity will develop depending on the opioid used. If you use fentanyl, it's much more. If it is less in morphine, the speed of injection of the drug and use of concomitant drugs. So low doses of muscle relaxant, propofol, pre-treated with benzodiazepine, all this can reduce the muscle rigidity. But whenever we have this, we have to be careful because quickly the patient will start to desaturate. And we have to be very careful in patients who have Parkinsonism because the rigidity is very high in these patients. Coming to meiosis, this is the first slide which I have put. It's a common feature to all this. Meiosis and constipation will always occur in all these patients. So coming to meiosis, here we have Edinger-Westphal nucleus in the midbrain, and this Edinger-Westphal nucleus will has an afferent part from the light and the inhibitory neurons, and the efferent pathway goes through parasympathetic nerves in the ciliary ganglion, and it will innervate the sphincter pupillae. So light causes meiosis. If the light activates the Edinger-Westphal nucleus, it will cause constriction of pupil. And hypercarbia, hypoxia, all this will produce mydriasis. Opioids inhibit this inhibitory neurons and produce high amount of meiosis. Even low doses of opioids, they cause meiosis. And it was first thought that meiosis is proportional to the analgesia. So they developed some monitors called a pupillometer. I wanted to show this video, but it's not there with me now. This pupillometer, as you give a opioid, the meiosis will start to increase. And with this, they have developed an index called the pupil unrest under ambient light. That is a PAL index, which can tell you how much of analgesia is derived from a particular opioid. Effects on respiratory system. All the inputs and outputs from the respiratory system are inhibited. From Pons, the Brie-Boettinger complex, the cortical regions. Opiates can block everything. So rate and depth of the respiration is decreased on administration of opioids. There is a reduced response to carbon dioxide and hypoxia also. But on the positive side, we have an antitussive effect, and that also blunts the stress response to intubation. Coming to CNS effects, as with all other anesthetic agents, they reduce the cerebral metabolic rate and CMRO2, and a specific effect, a different one, which from the inhaled anesthetic, is that it can reduce the cerebral blood flow. when you give inhalation anesthetics, the decrease in cerebral blood flow is more prominent. It does not have any effect in ICT, though we think that giving an opioid and patient becoming sedative, his hypercarbia might increase ICT. That effect is actually not seen. And the delta and kappa activation can produce some amount of neuroprotection in ischemic brain models. Coming to CVS effect, there's no significant effect of contractility. This is the basis for using high opioid anesthesia in cardiac anesthesia in the previous years. Now it is not used. And sometimes because of the reduction in the CNS output, it also can produce bradycardia. But all opioids have got some amount of anti-arrhythmogenic effect. And it has got no coronary circulation effect. There's no stale phenomenon in any of the opiates we're using. So it is very safe to use in all the cardiac patients. And like how we saw in neuroprotection, kappa-mediated bradioprotection is also there. They have got some amount of preconditioning and post-conditioning effects. Coming to effects on G8, the very disturbing effects. The main thing is nausea and vomiting. There are delta receptors in the chemoreceptor trigger zone located in the area prostrema of the floor of the fourth ventricle. All these opioids can stimulate this chemoreceptor trigger zone and produce vomiting. And the transmission involves complex dopaminergic, cholinergic, and serotonergic pathways. That is why one drug is not useful in preventing nausea and vomiting. It is also aggravated by movement. The inputs from the middle ear, they come. And if you have given an opioid anesthetic in the patient, you move this patient here and there, he'll start to vomit more. And the other interesting thing is the high doses of these opioids itself, they'll inhibit the vomiting center. That is why when we give very high amount of fentanyl, vomiting is depressed also. Preoperative ondansetron and dexamethasone have been shown to be effective, but not completely. The other distressing effect is the biliary spasm. It is because of the contraction of sphincter of OD, we produce biliary colic. I still remember when I used high dose opioids for ERCP, the surgeon could not cannulate the sphincter of OD and go into the injector dye. So he was asking, what is the opioid you use? How can you reverse it? So that much of contraction it can produce. And calculus pancreatitis, you can use morphine. There is no evidence that it produces more colic. And this biliary spasm is fully reversed by naloxone. Specifically, pethidine cannot be reversed by naloxone. Other agents are glucagon, NTG, atropine, all this can reverse. If you look into which drug produces maximum biliary spasm, it is the fentanyl, and butorphanol produces the least amount of biliary spasm. Opioid-induced bowel dysfunction. So these mu receptors are widely distributed. We saw they are distributed in the CNS. It is distributed in the enteric nervous system also. This will inhibit the bowel movement. So this causes delayed gastric emptying and contraction of bowel sphincters, which will directly produce constipation. So this is because of the depressed colonic movement and increased water absorption. On the other side, good side, they have been used as antidiarrheals. But in patients who have cancer or on chronic opioid therapy, it will have a distressing problem with them, and there's no tolerance. Even if you give them for 2 years, the constipation will remain. So now we are developing peripheral opioid antagonists for tackling this opioid bowel dysfunction without reversing analgesia. The 3 drugs in this class are methyl naltrexone, naloxegol, and albumopan. Methyl naloxone is only a parenteral agent. It can be given subcutaneous OD 12 mg for chronic opioid patients or who are treated for cancer. Naloxegol is an oral agent. It can be given 12.5 to 25 mg per oral, and that also can be given for patients on chronic opioid therapy. Albumopan is a new agent. It is not effective orally, but it is extensively studied for treating patients who are having postoperative ileus because of high dose opioid in the intraoperative period. So these 3 drugs are peripherally acting opioid antagonists. Opioids in obstetrics. So they are totally not teratogenic. A variety of animal studies have been done. They are not teratogenic. You can easily use them in patients who are posted for oocyte retrieval. And the thing is, they can aggravate the hypotension due to aortic cable compression because of the vasodilatation. So you have to be careful when you use them in the cesarean section when you put spinal anesthesia. and they can be transferred into the fetus, and this particularly increases when there is fetal acidosis. This is where all these agents have different amount of fetal transfer, but whatever you give, definitely the fetus will have some amount of respiratory depression, and you'll have to be ready with the pediatrician to tackle that. And when breastfeeding, definitely it will be concentrated in the milk, but the neonatal effects are minimal. They say that pethidine has got the least effect here. After 16th week, any fetus will have some amount of pain. So you have to give analgesia for the fetus when you do a fetal surgery. They have found that even instilling sufentanil into the amniotic fluid will give some amount of analgesia in the fetus when you have a fetal surgery. And mothers who are opioid dependent, when they have deliver a baby and suddenly the baby is withdrawn from the opioid, they will develop neonatal abstinence syndrome with irritability, cry. So that will also have some amount of cardiac effects, and it could be dangerous for the child. Coming on immunity, like how there are opioid receptors in the GIT, there are also opioid receptors in the immune cells. So they are modulated by the mu receptors, and morphine has the greatest immune suppressive effects. It is reflected as delayed wound healing. The fibroblast coming into the wound and healing, that is delayed. And they have also found that patients who are on opioid-based anesthetic during a cancer surgery, or comparing with the patients who are on a neuraxial block cancer surgery, the regression, the progression of cancer is more in patients who have had a opioid in the intraoperative period. Coming to pharmacokinetics, now we are all using drugs which are which are mu agonists. So there is not much difference between all these drugs. But when you choose a drug, it is always based on pharmacokinetics. So we will have a little understanding on what happens when a drug is administered. When it's given intravenously, it fills the central compartment as a plasma. That is the central compartment is filled first. Then what happens is this drug goes into a rapidly equilibrating compartment and the effect site in the next phase. Then slowly it goes into the slowly equilibrating compartment. So the onset of drug is dependent on the effect site concentration, or CE. That depends on the plasma concentration in the central compartment, CP. The plasma protein binding, if it is highly protein bound, it will not let it to the effect site. And the third thing is lipid solubility. If it is highly lipid soluble, it can escape the plasma protein binding and it can move into the effect site. And the amount of unionized fraction which is available to cross into the biophase and produce the effect. The duration of bolus which you give depends on rate of elimination. This is called the Q factor. The rate of elimination will depend how long will the bolus produce an effect. The infusion rate depends on the volume of distribution in steady state. What do we mean by steady state? So once you give the drug, it will fill the central compartment. It will go into the rapidly equilibrating compartment and the effect site. Then it will slowly move into the slowly equilibrating compartment. By the time the drug concentration in the central compartment will greatly reduce. So it is in this phase, you will have to keep replenishing the drug, which is moving into all these compartments. That is called a steady state. The infusion rate depends on volume of distribution of steady state and terminal elimination. So coming to the general properties of the opioids, all opioids are weak bases. They dissociate at the physiological pH. They dissociate into base form and a protonated form. So given morphine sulfate, it will be either in a base form, which is morphine sulfate itself, or into a protonated form, which is morphine plus. Only the unionized non-protein bound form penetrates in the biophase and produces the onset of action. So let us look at this chart and understand the pharmacokinetics of individual drugs. See the pKa, when it moves farther away from 7.4, the unionized fraction is very, very less. Look at fentanyl. We always thought fentanyl is a very wonderful drug, but see the pKa of fentanyl is 8.4 and the unionized fraction at pH is very, very low. Whereas look at this alpha-fentanyl, it is near the physiological pH, and the amount of unionized drug at the physiological pH is very, very high for alpha-fentanyl and remifentanil. This has got clinical implications, which we'll see in the next slide. And coming to the octanol water parturition coefficient that determines the amount of lipid solubility. sufentanil score first here. We already saw that there's a sulfur molecule in its nucleus that will produce high amount of lipid solubility. Morphine is the least lipid soluble or highest water soluble drug. So that also has got implications on how these drugs behave. Coming to plasma protein binding, the least plasma protein binding will have the maximum diffusion into the effect site. So though morphine has got some negative factors, this reduction in plasma protein binding will increase its diffusible fraction into the biophase. Whereas sufentanil has got high amount of plasma protein binding. Coming to the clinical correlate. Look at this. If you give all drugs together and look at how these drugs achieve high concentrations in the effect site, you can see that highly unionized fractions of alpha-fentanyl and remifentanil allow quick effect site concentrations. So see here, the bolus has started. The first concentration rise will occur only with alpha-fentanyl and remifentanil. They increase very highly, produce a rapid effect. So if you suppose if you want to attenuate the stress response to an intubation, these drugs are the best drugs. When you give it together with the induction, alpha-fentanyl, remifentanil will produce good amount of effect and it will quit the area also. So this is how they behave. Coming to high lipid solubility of sufentanil and fentanyl, they start late, but the effects are very sustained. So whenever you give fentanyl as an anesthetic, as a part of an anesthetic, you will have to wait for at least 5 minutes for effect site concentrations to rise and the effect to come. So immediately this fentanyl effect will not come. And another thing about the high lipid solubility is that fentanyl is actively taken up into the lungs. Once you inject, quickly it will go on 85% will fill the lungs and then only it's slowly released. So you can see that the concentration high reaches high in the at the 5th minute and it slowly comes down because of the slow release from the lungs. Coming to morphine, morphine achieves the effect site concentration only after 20 minutes. So if you are giving morphine as an anesthetic, you have to really wait very long time. And because of the higher ionized fraction, it binds to the receptor very nicely and its effects last longer. See here, for the morphine, the effects has started to come only after 10 to 15 minutes, but the effects keep rising as the time goes out. Coming to the 3-compartment model kinetics and looking at how these drugs behave in infusion, you can see that remifentanil has the shortest half-life in the first phase. That means that once you inject remifentanil, immediately it will start to go into the effect site and start producing its effect. And it has got very less amount of volume of distribution also. Whereas if you use fentanyl infusion, it will take some time to the effect to come, but at the same time, it will last longer also, where you have to be careful when you stop the infusion. So when you come to giving an infusion, see this remifentanil has instantaneously produced a effect site concentration, whereas fentanyl will produce a very, it will actually be distributed because of its lipid solubility and its protein binding. It will be widely distributed. It will take a very long time to actually produce analgesia. So you will always have to give a bolus when you give a fentanyl and then only start an infusion. Directly starting fentanyl infusion will never give you any help. Coming to how these drugs behave after stopping an infusion, this is called context sensitive half time, which means after a very long infusion, when you stop the infusion, how long the drug effects start to come down. So this is given by this back-end kinetics diagram. You can see here, however long if you give remifentanil, once you stop the infusion, the remifentanil concentration will immediately go down. Whereas see, look at fentanyl, as the duration of fentanyl infusion has increased, if we give for a very long time, it takes very, very long time for the fentanyl concentrations to come down in the body. So once you stop the fentanyl infusion, at least for 6 to 7 hours, you have to monitor these patients carefully, which is not the case of remifentanil. Coming to some pharmacology of individual drugs, first we'll talk about the tramadol hydrochloride, which is commonly used. It is a racemic mixture of both LEVO and R forms. All these drugs will act only in pure form, either L or R form. But here, this is a racemic mixture, and the pharmacological effects depend on 50-50% of L and R forms. The analgesic effect of both forms come with different mechanism of action. One form is a pure mu agonist.
Meeting you want to see this meeting? ನಾನು ಅಕ್ಕನ ಡೈಲಾಗ್ ಇಲ್ಲಾಂದ್ರೆ ಈಗ ಮಮ್ಮಿ ಮಾಕಾಳಿ ಆಗ್ತಾರೆ ಅಂತ ಹೇಳಿ.
The other part is through the inhibition of serotonin and noradrenaline uptake. So the different characteristics of tramadol is that it can it's a very good analgesic, and because of the noradrenaline and serotonin reuptake inhibition, it can also produce some amount of antidepressive effects, and it can elevate the mood. So though it is less potent than morphine, the analgesic effect because of these two mechanisms is very good. The tramadol effect is dependent on CYP2D6 for its effects. Means that tramadol is a pro-drug. Once you give it, liver has to metabolize into active metabolites, and then only it can be become an active congener. So the CYP2D6 has a variety of heterology in different individuals. That is why in one patient's tramadol may be very effective. The CYP2D6 is active. The tramadol is very active, and some patients it might not be effective and produce more side effects. And this drug has got high amount of nausea and vomiting, and now they are finding that it has high antibacterial activity. That is why the use of tramadol in epidural is increasing, because they have shown that this drug has high antibacterial activity. And you have to be very careful when giving tramadol to patients who are taking SSRIs, because it can precipitate serotonin syndrome, which is very dangerous. So psychiatric patients give very tramadol very carefully. Better to avoid it. They may produce a lot of dysphoria effects. And on the other hand, they can also land up in serotonin syndrome. Coming to buprenorphine hydrochloride, it's a thibine derivative. It's highly lipophilic. As we already saw in the classification, it is a mu receptor partial agonist, whereas in the kappa receptor, it's a pure antagonist. It is 33 times more potent than morphine, but the activity is less than morphine. It also binds tightly to the receptors. If you see that T half KEO, for fentanyl, it's only 6 minutes. That is, the fentanyl will unbound from the receptor within 6 minutes. But once buprenorphine binds to its receptor, the mu receptor, it takes 166 minutes for its unbounding from the receptor. So it becomes long acting. It has got a slow onset. It peaks in 3 hours, but the duration of its action is 10 hours. That is why they are adding this drug into the spinal, epidural, and the nerve blocks. And it has also got a ceiling effect for respiratory depression, because it's a partial agonist. Up to 3 microgram per kilogram, it behaves like morphine. Above that, the respiratory depression does not ever occur. The kappa receptor antagonism produces some amount of antidepressant effect also. These are the positive effects of buprenorphine hydrochloride. Coming to pentazocine lactate, in one era where we didn't have fentanyl, we were using pentazocine as the chief anesthetic agent. It is a kappa receptor agonist, and it is less potent than morphine. At the mu receptor, it might act lightly act as a agonist, but most of them it is an antagonist at the mu receptor. The analgesic and respiratory depression have a ceiling dose at around 70 milligram. The normally each ml contains 30 milligram. If you give 2 ml, and after that there is no respiratory depression, after that respiratory depression will not ever occur. And sometimes physical dependence may develop even though it has got a dysphoric effect. The chief characteristic of this drug is it stimulates the sympathetic system and increase the catecholamine output. So there will be some amount of tachycardia, increase in SVR, BP, and contractility. This is actually mediated by the delta receptors in the heart. And as I already told you, this agonist antagonist drugs have got some amount of antipruritic effect if you use them with the spinal fentanyl. So this pentazocine has been shown to be really effective when there is pruritus when you use spinal fentanyl. Coming to butaphenol, this is also a kappa receptor agonist and a mu antagonist. It has got a rapid onset and peaks within 1 hour, but the duration is only 3 hours. Excellent drug for giving in the postoperative period. And this drug also has got a ceiling effect of respiratory depression. This also stimulates the sympathetic system. The characteristic feature is that it decreases the pulmonary pressure. There have been reports of patients developing pulmonary edema after butaphenol tartrate injection in the intramuscular period, the postoperative time. Coming to nalbuphine, it was almost a forgotten drug. Now again it's being used. Apart from its kappa activity, it has also got some delta receptor activity. There's a quick onset and a long duration of action. Added with morphine therapy, it prevents the low dose of nalbuphine. If you give with morphine therapy, it prevents dependence and tolerance. And it also prevents pruritus after neuroxyl opioids. Coming to sequential administration of agonist and antagonist, see, you might have a opioid-based anesthetic with a pure agonist. In the postoperative period, you might like to give any of this agonist-antagonist drug. Is it advisable? That acute administration of agonist-antagonist in opioid-dependent patient will precipitate withdrawal because it will displace the mu receptor agonist from that receptor. Clinically, they should not be used for opioid reversal. But when you administer these drugs for postoperative pain relief after pure agonist, you should be careful or it is not recommended because the patient will be having good analgesia and euphoria in that period. Suddenly administering a drug like morphine, drug like butorphanol, nalbuphine, the patient can have some dysphoria and reduction in the analgesic quality for some time. Coming to naloxone, it is a N-allyl derivative of oxymorphone. It is a competitive antagonist on all opioid receptors, meaning if you have an pentazocine overdose or a buprenorphine overdose or even a nalbuphine overdose, you can use it. It's not just for morphine and fentanyl alone. Administration into opioid naive patient, that is a patient who has not got opioid at all, it will increase the heart rate, it will reduce the food intake and alter sleep patterns, and sometimes increase the BP in septic shock patients. Other than this, naloxone has got no discernible effects on patients who have not received any opioid. But if you give it to a patient who has already received opioid, you can give it through intranasal route, IM, whatever route you give it. It has got quick absorption from the injection site, and it rapidly achieves concentration in CNS because of its allyl molecule in the allyl nucleus and molecule in the nucleus. It becomes widely distributed and starts to antagonize the effects of opioids. Liver also conjugates into naloxone 3-glucuronide, which is also an effective component. But the thing you have to remember with naloxone is the clearance is very high and the effects last only for 1 hour. So if you suppose you're reversing an effect of morphine with naloxone, the patient will wake up faster. But after some time, he'll again go into sleep. This is called re-narcotization. So you have to be very careful with this. So you have to have additional doses to counter that effect. The usual dosage in an emergency setting is 0.4 milligram to 0.8 milligram infusion over 10 minutes. Never give it in a direct bolus. Patient will have a sudden increase in pain. So never give it as a direct bolus. Give it as an infusion over 10 minutes. Or 2 milligram, then maintain with the 2 milligram in 500 ml that it will give a concentration of 4 microgram per ml at 100 ml per hour. You can also use it as 40 microgram bolus every 2 to 3 minutes. For newborns, if they have given an opiate to the mother and the newborn is depressed, you can use it at 0.1 mg per kilogram bolus and repeated bolus till the child becomes fully awake. What you have to be alert is rapid infusion can cause severe pain, tachycardia, sweating, myocardial infarction, arrhythmias, and pulmonary edema. Coming to the newer things, novel delivery systems, we have neuraxial opioids and the delivery systems, transdermal therapeutic systems, oral transmucosal fentanyl, ionotophoretic fentanyl, and extended release of the epidural morphine. Word about neuraxial opioids. They are classified into two distinct types. One is the hydrophilic opioids and the lipophilic opioids. Hydrophilic opioid is the classic example is morphine. It has got slow onset when you give it in the either in the spinal or in the epidural, but it has got a long duration of effect and it has got high CSF solubility. That is, it will not easily cross into the CNS very easily. It will stay in the CSF and will act and will produce extensive CSF. The advantages of these properties are a prolonged single dose analgesia, minimal dose compared with IV administration. Suppose if we give only 8 to 10 grams of morphine, that can be achieved with 1 to 2 milligram if it is given in the epidural, and thoracic analgesia with lumbar administration because it's extensively spread. Even giving in the lumbar area will produce thoracic analgesia. The disadvantage is that the delayed onset is there and it has got an unpredictable duration. Sometimes morphine effect we have seen up to 24 to 28 hours. Morphine effect will be there. Higher incidence of side effects and delayed respiratory depression. That is a very troublesome. We have given morphine at in the morning and sometimes patient becomes so sedated and respiratory depressed in the evening. That is the problem with morphine. Coming to lipophilic opioids, they have the advantage of rapid onset, short duration and low CSF solubility. The advantage is that it can be ideally used in cases of patient-controlled epidural analgesia. But the problem is a single dose will be very short duration. Systemic absorption will be there and it will cause all the pruritus, everything will come. And if you give it an epidural in the lumbar, thoracic analgesia, it will not be there if you use a lipophilic opioids. There is a different discovery which is in the recent time called the nociceptin opioid receptor. The search for endogenous ligand led to nociceptin, which is a 17 amino acid peptide, which is widely distributed in the descending pain pathways. They have found that spinal injection of this nociceptin or orphan in FQ produces intense analgesia, and systemic administration produces moderate analgesia without any side effects. So they are developing a nociceptin-like ligand called cibranopodol, which is classed the phase 1 and phase 2 trials, and it is yet to go into the neuraxial opioid list. Coming to transdermal therapeutic system, we all have seen the fentanyl patches and buprenorphine patches. The characteristic which will make them use in that area is high lipid solubility, low molecular weight, high potency, and no skin irritation. Only if these compounds have these 4 properties, they can be used. The advantages of these patches are there is no first pass metabolism, consistent analysis in the postoperative period, and very convenient for the patient. Transmucosal delivery for these 3 drugs are there. The fentanyl lollipop, buprenorphine sublingual tablet, and this is called Suboxone sublingual film. This is commonly used for opioid dependent patients. You might have all seen that some patients they quickly respond to opioid therapy and some resistant. This is because of a mutation called A1186 mutation in the chromosome 6, which has a OPRM gene for mu receptor. So if these patients have these mutations, the drug effects won't occur easily, but the side effect profile will remain the same. Coming to biased agonism, morphine, when it's bind to mu receptor, it will activate G protein, as I have already told you. They also induce another compound called B-arrestin, which will produce respiratory and decrease in respiratory function. Now they are into finding new compounds that will only activate the G protein and produce analgesia without respiratory dysfunction and GI function. Mitragynine and the cibranopidol, they have new ligands that do not recruit beta-arrestin. So this is the future of opioid therapy. Coming to this meiotic pupil, there is one interesting story which I read long ago called Harmful Intent by Robin Cook. In that, the anesthetist named Jeffrey Rhodes, he will be penalized for having a reckless anesthetic course for a lady which dies in the peripartum period. So the nurse will testimonize in the court telling that he was under the influence of opiates. I saw his constricted people. So the meiotic people will tell, the jury will tell that he is opioid under the influence of opioid in the perioperative period. He penalize him. So that is how the story goes. Thank you all. And I think it is a very huge topic. So I have covered some important areas which you might not understand. So let this be a stimulus for you to read much more. Thank you very much.
Thank you, sir. Thank you, sir, Professor, for your wonderful presentation. You have presented it in a very interesting and a very understandable way. Thank you very much, sir.
Thank you, sir.
A few questions are not there. I will ask you some questions. So regarding this transdermal application, yes, whether we can use in acute pain, that is postoperative pain, transdermal.
Sir, it takes some time for the effect to occur. So it should be ideally these patches should be pasted in the preoperative period, so that once the patient comes out of anesthesia, they have a stable concentration of these drugs in the blood level. And once we remove it also, we have to be very careful. The fentanyl patches are notorious. The skin and subcutaneous tissue act as a depot for this fentanyl. So they will, even after removal of the fentanyl patches, their effect will be prolonged. So acute effects will not be there. We have to put them in the preoperative period, and after we remove also, we have to monitor these patients.
Yes, sir. That was my second question. I thought that is you have to apply very earlier. There is a period of lag period. So you have to cover some other analgesia for that lag period of 24 hours. Suppose you are applying in the post-operative period. So thank you very much, sir. Thank you. So we come to the last session of today's session. That is very interesting topic by Dr. Rajesh, that is basics of echo, what anesthesiologist should know. He is a professor of Department of Anesthesia, and he is also acting as a medical superintendent in charge in Indira Gandhi Medical College Research Institute, Puducherry. He has more than 15 publications, and he was the vice president of ISA Puducherry State in the year 2012 and 13, and he was the governing council member of ISA South Zone 2013, and he is the past president of ISA Puducherry State 2018. He is master in trans-esophageal echocardiography and ultrasound blocks and conducted many workshops. He has attended as faculty in many conferences and CME. He was the organizing chairman of many state and South Zone conferences of Puducherry. So we welcome you, sir. Over to you, Rajesh, sir.
Thank you very much, sir. Am I audible? Is it clear,
sir? You are audible.
Thank you very much, and very warm good morning to everyone. Warm Sunday morning. Today's session is on basics of echocardiogram. This, as Dr. Edward Johnson sir has told me, that we will be having 2 or 3 sessions on this echocardiogram. So what I have done today is to just give you an introduction to transthoracic echocardiogram, what every anesthesiologist should know. Okay, so today's session, the objectives are the focus, point of care ultrasound. What is the meaning of focus, and what are all the different components of focus, and why anesthesiologists should know about transthoracic echocardiogram. Then, what are the basic views, how to get those views, and once you get those views, what exactly what structures you have exactly to recognize in those views, and then finally to conclude, how to assess the LV systolic function, because that is the very basic thing which you need to know when you are doing echocardiogram. Okay, so to start with, what do you mean by focus? That is point of care ultrasound. We have been listening to this word for the last 1 or 2 decades. So basically, what does it mean is, by utilizing the ultrasound, we are going to take care of a limited examination for a well-defined clinical question. That's the most important part. This question is it should be well-defined to guide the patient management with the intention of improving the patient outcome. Okay. So what are those questions? For an example, if you are dealing with the in a preoperative room, if you are assessing the patient, emergency patient, the question may be like whether the patient's stomach is full. For this, you need to do a gastric assessment. Or in case a patient is not hemodynamically stable, we would like to do a transthoracic echocardiogram. You can just ask the question whether the patient's LV function is good, or does this patient need more fluid, something like this. So these, once you frame these type of questions, so for this question, you need to find the answer through localized or focused examination. This is what is point of care ultrasound. But remember, this point of care ultrasound is just an extension of your clinical and physical examination. That's very important. But we know that for the last 2 or 3 decades, we anesthesiologists have been using the ultrasound for a long time, especially for performing a lot of blocks, and also to vascular access and many other like airway assessment and lung ultrasound, many things we are doing. So recently, this is the most important one, which I'm going to talk about, focused transthoracic echocardiogram. Okay. So what type of echocardiogram we are going to practice? Is it a comprehensive one or a focused one? No, we are not going to do a comprehensive assessment of the through the echocardiogram, but we are going to do what is called as focused or goal-directed echocardiogram. That is a point of care echo, what I have already told. Why we anesthesiologists should be aware of this? Because this point of care ultrasound is being done by the treating physician. So if you are treating a patient who's hemodynamically unstable, it does make sense that if you know how to do this echocardiogram, because the questions are going to be formed by you, especially when a patient who is deteriorating, you have to know that whether am I doing anything wrong, or what way I could inform or improve the patient outcome. So like doing this transthoracic echocardiogram, you can analyze so many things which we'll be seeing in the subsequent classes. And also a disclaimer here, but remember that the type of echocardiogram we are doing is a focused echocardiogram, and it is not a comprehensive. So it cannot replace an echocardiogram done by the cardiologist in a very high-end machine. This is only to improve or elevate or augment your physical examination. This is a very important point we need. And another thing is, what are all the, why we should know? What are all the significance and what are all the importance of doing this transthoracic? First and foremost is, it gives you a quick and reliable information. Because, for an example, if you want to do a chest X-ray, you need to wait for the radiographer to come to the patient by side. Then the film has to be developed. It may take at least minimum 20 to 25 minutes. So you will be wasting a lot of important time at that. Unlike that, you have a machine. If you have a machine in your hand, you are going to do immediately, and you'll find out what is happening inside. And second thing is, it does give you a real-time image. That means you are seeing the image like how as it happens. It's a real time. The third most important thing is non-invasive, and most importantly, it is the evaluation done by the echocardiogram is dynamic. It means you are going to see the change for the treatment which you have started on. So that means it is not a one-time, it's not a static imaging modality like a ECG or a chest X-ray. It is a dynamic one. Because due to this, every one of us should be aware of how to do a basic transthoracic echocardiogram. But at the same time, remember, the point of care echo will tell you how to assess the qualitatively, not quantitatively. Of course, quantitatively also we can learn, but that's an advanced technology. But as an anesthetist, we all should know qualitative assessment. Okay, since this is a qualitative assessment, training and experience are very, very important. Okay. So having said that, with this introduction, we'll just move on to the topic. Okay, let's start with the transducer. What type of a transducer we should have? Because as an anesthetist, we are very much familiar with these two types of transducer. You are high frequency linear probe as well as the linear probe. But for doing an echo, you need to have what is called as a phased array. So this is what is the phased array. You must have seen if your ultrasound machine does come, if it come with the probe, just kindly examine that. This is the phased. The one important thing which you need to know in this is what is called as this orientation knot, either as a group or as a small knot. This plays very, very important because based for an echocardiogram, this positioning of this orientation marker only defines the image which is going to be generated. And second thing is holding of the probe. How are you going to hold the probe? So this is the way you have to hold the probe. To do it like a pencil holding, and your palm should be touching the patient so that a firm pressure should be elicited on the thing. And there is a small thing in this because this area has to be well covered with jelly. So because sometimes it may be very difficult to get an image because of the inadequate of the jelly. Because of the air interface, the images may not be clear. So after applying the jelly, you have to perform the produce a sort of a firm pressure on the patient and hold the probe. So conventionally, the orientation marker, this denotes the orientation marker. Orientation marker comes to the right upper quadrant of the frame of the screen. So conventionally, it will be like this. And if it is not there, you have to change it. Only then the basic images will not change. Okay. So next is how to get an optimal image. So there are two things are important. As in any other ultrasound modality, gain as well as the depth. So when you say gain, it is about the amplification of the image, where all the cardiac structures will be seen as gray, something like this, and the blood will be seen as the black, and this white glistening will be the peripheral. But imagine if your gain is not correct, you will be getting the images like this, by which you will not be able to get any information. The next thing is your idea depth, because every image has got a marker for the marker points, which I'll be telling you a little later. So any unnecessary depth, for an example, this image shows you insufficient depth. Here you may not be able to get information. Here you are losing the valuable area here by giving excess depth. So you will not be able to analyze the image properly. So because of this, you will be losing a lot of empty space. So because of that, so you have to plan for perfect gain as well as the ideal depth. Okay. So what are all the different imaging technology? First thing start with, there are three types of imaging. So first is the 2D imaging. That is the basic mode. That is some of the machines will come out the nomenclature like a B mode. It allows the image to be seen as the two-dimensional. This is the mainstay. And second thing is the M mode, which gives you only one direction. So this is the basis of the B mode. So imagine the cardiac is lying like this, and your ultrasound beam is going to intersect the cardiac at three sections. Something like a sagittal or a long axis. This is the long axis. This is the long axis. And then one plane will be the short axis. The third will be the coronal section. So we will be studying the heart in these three sections in this 2D mode or a B mode. Whereas in M mode, it will be seen, the image will be studied in a against the moving objects against the time. This is the image you will be getting. So especially useful when you are studying the valve. And third thing is the Doppler. Doppler is something like to assess the blood flow velocity. Here we compare the frequency change between the transmitted one, that is the beam that is going generated, as well as the reflected sound. But we are not going to see these two things today. Maybe the next class we'll be discussing about this utility of the M mode as well as the Doppler mode. Today we are going to see only about this 2D imaging. So what are all the views? When we talk about any echocardiogram, first thing you need to know how to get the image. So for that you need to know what are all the views we need to do. So there are three basic views. One is parasternal, second one is the apical, third one is the subcostal. Parasternal is divided into two views. One is the long axis, where we are studying the heart in the long axis. Another one is the short axis. Then you have the apical. Apical, you will be having apical 4-chamber view, then apical 5-chamber view. In subcostal, we have the subcostal cardiac view as well as the subcostal IVC. So these are the basic views we all should know. Okay. So when we are talking about view, we should know how to put the probe, or rather where to put the probe to get the image. So for that, we know that since the heart lies inside the thoracic cage, it is covered by the lungs. But we know the air is an enemy for the ultrasound. So that most of the places, the ultrasound beam is not covered. So there are few areas which are called as acoustic windows. Through only in those areas, we will be able to analyze the image of the heart. So these are the images. The number one, as the name implies, is the parasternum, because it just lies adjacent to the sternum. The left to the third or fourth intercostal space can have this parasternal window. That's the number one. Then you have the apical window. Apical window is at the apical impulse, at the place of the apical impulse. Then third is the subcostal window, that is 1 or 2 centimeters below the sternum. And then fourth is the suprasternal notch. But usually, conventionally, we don't practice this because it's an advanced mode of assessment. Okay. So now let's start with the parasternal long. So first thing is how to position the patient. But you would have seen that cardiologists always perform the echo by this position. But we do not have, or we may not have, this type of luxury unless we examine the patient in the preoperative. So most of the time, either on table or in the ICU or in the postoperative bed, you will not be able to make up this patient to this position. But however, if possible, this is the ideal position, patient lying to the left leg. And to get the parasternal long axis view, so you have to place the transducer in the second or third intercostal, or up to second to fourth. It may vary from patient to patient at the intercostal space. And the important point here is this is the orientation marker has to be facing the right shoulder. This is very important. The orientation marker has to face the right shoulder. By doing this, the ultrasound beam travels like this. So we know that the axis of the heart lies like this. So it just goes parallel. That sagittal plane of the heart is the bicep. So between the right shoulder, the plane should be between the right shoulder and the left. So when this beam is intersecting the heart, this is the one which we are talking about. It's a long axis plane. This is the one. This is the one which we are going to study now. Okay. So then imagine that this is the cut section of the heart. This is what you will be seeing in the echocardiogram. This is the place which is closer to the spleen because your probe comes, your beam comes like this. So as a result, this is what you will be seeing on the top of the image. The water seen is the right ventricular outflow tract. Then you will get the interventricular septum. Then you will get the left ventricle. Then left atrium. Between the left atrium and left ventricle, you will be seeing the mitral valve. Then you have the aortic valve, left LVOT, and the aorta. Part of the aorta will be seen. So this is another image, and you will be seeing the pericardium at the lowermost part of the screen. So this is what exactly when you put the probe in the parasternal in the exact position, this is the image you will be seeing. The topmost part will be the right ventricle. Then you have the interventricular septum. Then you have the cavity, left ventricular cavity. Then you have the mitral valve. This is the anterior leaflet. Then here since the mitral valve is open, aortic valve is closed. You have the aorta starting up to some part of the tubular aorta will be seen. And this is the descending. So as far as this plaque image is concerned, this descending aorta has to be included in the image, and this should form the lowest part of your image because it will help you to differentiate between the pericardial and pleural effusion. Okay. So what are the structures and what are the interpretation you are going to do by doing this? Same thing, this right ventricle, you may not get better information will be provided in other views. This in review will not provide much information about the RV. But the most important thing is left ventricle. What is the size of the left ventricle and how does the function? How does it function? Then you have the ascending aorta, the size of the aorta, then the aortic valve, mitral valve, as well as pericardium. These are the structures which you can analyze in this image and you can interpret. Okay, we'll move on to the image. So this is the image, or this is how your plaques view will be seen. So you can see this is the right ventricular outflow tract. This is the LV cavity. Your mitral valve is moving, closing, and opening and closing. This is the aortic valve, and this is your LA, and here is your descending. Okay, let me pause this image. So if you see, so when your mitral valve is opened, you will be able to see the closure of the aortic. So in the information what you can get, you can see the mitral valve is opening. So to some extent, you can rule out that this patient does not have any stenosis of the valve. Same way, when the aortic valve is open, so this is the aortic valve is well open. So you can rule out the cause to some extent, even though there are various methods by which you can analyze the mitral, you can pick up the stenotic valve. This will just give you a proved idea about whether this patient has got a stenotic lesion. Okay. So also you can analyze how the LV functions. Okay. So next is your parasternal short axis. So parasternal short axis is here we are going to study the heart in the short axis, where at 4 different levels. Starting from the cephalad, you have the aortic level, then comes down the mitral level, then the mid-papillary level, then epicardium. There are 4 levels at which in parasternal short axis view, you will be studying the heart. So how to get the image? This is the image which we have discussed earlier, where we are going to see the heart in the long axis. So what you need to do is just rotate the probe 90 degrees, the rectangle, so that the orientation marker is facing the patient left shoulder. So approximately around 2 o'clock position. And by doing this, you will be getting the heart in the cross section. That is your short axis. So how the image will look like? This is what. So if the image is on the cephalad side, you will be getting what is known as the aortic level. Then as you keep coming down, or as you sweep the image or beam down, so you just start looking down like this. So you'll be getting your mitral, then mid-papillary, then apical. So at each level, we can study various structures. So this is your aortic level. This is the aortic valve. This is the aortic valve. You have you have the right atrium here. Then you have the tricuspid valve will come here. This is right ventricle. and this is the interatrial septum, and this is the left atrium. And you will not see the left ventricle in this image because you are seeing the image. Imagine that you are seeing above the left ventricle. So as you start looking into the imagine you have started looking into the left ventricle starting from the left atrium. So now you are seeing this. This is you have started seeing your right ventricle here, and this is the mitral valve apparatus started coming into picture. Your mitral valve starts opening and closing. So now you are just looking into the left ventricle. As you move further, you start looking or sweeping the probe down. You'll start getting your papillary muscle. This is a mid papillary view. So now papillary muscle start coming into the picture. So now it's a mid papillary view. You are seeing the papillary muscle. Okay. So once you are familiar with this parasternal short axis view, then we will move on to the fourth chamber. So what you have to do here, imagine that, remember that in the parasternal short axis view, we have kept the transducer at third or fourth intercostal space, and our pointer was marking, or the orientation marker was pointing towards the left shoulder. So here what you need to do is you have to come down a little bit below, or if you are able to localize the patient apical impulse, that is the place where you keep the probe for obtaining the apical four-chamber view. And the orientation marker has to be pointed towards the 3 o'clock.
இந்த
3 o'clock position.
என் பஞ்சாம்பு தான்
There is a okay, so the position of the orientation marker has to be towards the 3 o'clock. So at this time, the plane, the beam of the ultrasound beam, the plane has to be traveling like this. It will be the coronal section. It will be, it bisects the heart in the coronal section. And another tip here, you should not look too much down. It will be a little bit tilted upwards. That is aim superiorly and medially towards the right scapula. That will give you an ideal image. So this is how your coronal plane bisecting, and this is the image you are going to see. Okay. So this is how the image will be coming. This is the top of the screen, and the one which is on your right is your left ventricle, and one on the left will be the right ventricle. And below this is the right atrium, and below the left ventricle is the left atrium and corresponding valves, mitral valve and right ventricle. This is the image where you will be seeing all 4 chambers in a good way. This is how image will be seen. Left ventricle on the right side, right ventricle on the left side, right atrium and the left atrium. So what are we going to see? This is very important. Even though with the next session, we will be discussing about each and everything. But to just for the completion sake, you need to understand. Here you need to compare the size of the right and left ventricle. We know that always left ventricle is bigger in size. That should be the normal. If the right ventricle size is bigger than the left ventricle, then that's a problem. Then I have the left atrium. Then mitral valve. Mitral valve studies, studies can be done here. Same way, right atrium and tricuspid valve also can be studied first. And the regurgitation and stenoticulations can be studied here. So once this 4-chamber view is done, then what are we going to do to get the left ventricular or 5-chamber view? You just tilt the same place from where the 4-chamber view is assigned. From the same place, you just lift the probe antero-superior. So you will be seeing the LVOT and the aortic. And from this view, you will start getting the aortic LVOT with the aortic valve. And this is the 5th chamber. That's why it's called A5C, aortic 5-chamber. Okay. Aorta is the 5th chamber. So this is the 4-chamber view. So you see the left ventricle is bigger than the right ventricle. You clearly see the mitral valve opening and closing. This is the left atrium. This is the right atrium. tricuspid valve is not clearly seen in this image, but you need to adjust your probe and you'll be getting it. Once you start tilting the probe anteriorly, little bit superiorly, you will start getting the opening up of, you'll start getting the aortic valve. So this is how the aortic valve will be seen. LVOT, the aortic valve. This image will be used to study very advanced, especially the cardiac volume calculation, stroke volume calculation. For this image will be very okay. So once these views are done, next we'll move on to the subcostal. So the subcostal view is a very, very important view because practically what we have seen is, especially when the patient is in the ICU, you may not be able to get those views, Black's view or short axis view, especially if the patient is on ventilator. Very difficult. You may not get the ideal views of all the views, ideal images in all the views, but you have to do all the views and then you have to correlate the findings. And most of the patients getting a subcostal view is very, very easy because it doesn't penetrate through the lungs. It does penetrate through the liver because liver is reasonably a better medium. So this image will give you many information which you will not be able to get during your regular views in the eyes. So for this, what we need to do is place the probe in the around subxiphoid region, around 1 or 2 to 3 centimeter below the septicsternum. You place the probe, and orientation marker has to be at the 3 o'clock. Another thing with the important point here is, unlike the holding of the probe. So normally, I have already told you that you have to hold the probe like this so that your palm is sitting on the patient. But here, if you do that, you will not be able to get the image. So what you need to do is you have to do what is called as a palm down grip. That is, you hold the probe like this and then insert something like that. So there should not be, the entire probe should be lying below your palm. You have to do it like this, not like this. So only then you will be getting the image. So when you do this, this beam penetrates or bisects the heart in the coronal plane, and the image will be like this. What is the superior most part of the image is the liver, and this is the conduction medium. Through this, we'll be analyzing the heart, and the same way, like a apical four-chamber view, what is coming here is the left ventricle and the right ventricle, and this is the tricuspid valve, and this is the your right atrium, this is the left atrium, this is the mitral valve. So what are we going to see assess in this same way? All the image, whatever I was talking about the apical four-chamber view, you will be able to do this. But only thing is, sometimes we will not be able to do the Doppler studies in this because it is not exactly aligned. This Doppler is not aligned. So to complete the subcostal view, we need to get the IVC. For this, from the orientation marker, from the 3 o'clock position, you rotate the transducer 90 degrees to the counterclockwise so that your orientation marker is placed at the 12 o'clock. And by doing this, always keep the right atrium in the view because you have to make sure that the IVC drains into the right atrium. Otherwise, you will mistake the aorta for that. Many times it happens. So always make sure that when you are analyzing the IVC, which most of us are well aware, and analyzing it, always bring the right atrium into the picture. And this is the IVC. Okay, so once you get all these views, first what you need to do is you have to keep practicing it, how to get the image. But as I already told you that it is very difficult to get images, all the images in all the patients. Some patients you may not be able to get the long axis view, some patients the short axis view, and apical four-chamber it not be possible. So subcostal view, so you have to try doing all the views, and whatever the information you are getting from each view have to be put together and to make a interpretation as a whole. Okay. So before completion, I would like to know how to do a left ventricular systolic function. So whenever we talk about echocardiogram, what comes to our mind is the ejection fraction, correct? Because once we know that, especially during the preoperative assessment, if the patient does come with a echo report, and first thing which we look is EF. If the EF is 55, we are happy. If the EF says that 40, okay, 30, we are not very happy. So, but there are a lot of pitfalls are there by relying just by looking at the EF numbers, because this EF number is a fallacy. It will not give you much information that you will know once you start doing the echocardiogram on your own. because most of the ejection fraction reports that is given in the echo report is based on what is called as a Tichol's method, which is not an approved method. Either otherwise you have to do the EF calculation by what is known as modified Simpson methodology. But since it's very time consuming, most of the reports come with Tichol's method. Because the Tichol's method, we analyze the ejection fraction at only one point of the left ventricle. So if the patient has got any abnormal regional wall motion abnormality beyond that point, that will not be picked up. So inadvertently, this EF will give you a very pseudo high value. Or in other words, relying the LV function only on EF is not very much acceptable. So for this reason, you have to assess the LV as a qualitative method. So how are we going to analyze the LV function in a qualitative? So for this, especially in the bedside, when you are practicing a bedside echocardiogram, you need to follow what is called as an eyeballing technique. Yeah, many reports have, or many studies have clearly proven that this eyeballing technique is as equal, or rather as equal to the interpretation done by the cardiologist as far as the ejection fraction terminology is concerned. Okay. So what are we going to look at the left ventricle in the eyeballing technique? There are three important points we have to analyze. The first one is the change in the volume of the chamber between systole and diastole. So this side you have the diastolic one. So parasternal long axis. I am sure that by this time you would have recognized the view. This is the your diastolic one. This is the systolic. So just see how the chamber size is differing between these two. So entirely there is nearly about more than 60% of the chamber is constricted or the contracted during systole. That's a good sign. That's the first thing which you need to assess. The second thing is what is the change in the thickness of the wall, either the ventricular septum or the free wall. So the thickness should change more than 60% during the systole. So during the systole, the wall has to get thickened. That's the second thing which you need to look into. The third thing is your anterior leaflet of the mitral valve. This mitral valve anterior leaflet has to go towards the interventricular septum. How far it moves or how close it moves to touch the interventricular septum, that will give you an important aspect or important idea about the left ventricular. So when you are analyzing or qualitatively analyzing the left ventricular function, these are the 3 points points by which you will be able to analyze. So I'll just put you on another image where here you can see. So by applying the same principle, look at the difference between the chamber volume difference between systole and diastole. Hardly there is any difference. Even the systole, it is the same. And what happens to the thickness change? There's hardly any change in the thickness, and it is hardly your anterior leaflet hardly cross the midway. So if your image is going to be like this, then you can be very well clear that this patient has got poor LV systolic function. We don't whether we are not very bothered about whether it is 30 or 28 or 25, but we know that this patient has got poor LV systolic function. Okay, before completing, let me give you some example. So this is the plaques view, which the basic view everyone should start doing and know that. So by looking at this, you apply the same 3 principles here, just and see how the okay. Just see this now. So the chamber volume is getting between the systole and diastole, it's completely getting constricted, and the vessel, your walls, free walls as well as the septum is getting contracted, getting thickened well, and the mitral valve just goes and comes near the septum. So that means the this patient's LV function is reasonably, it's good. And we'll go to the next one. Just see this patient. Just assess how the, compared to the previous one, this is not doing well. That means this patient, by looking at this image, you can say this patient has got moderate LV dysfunction. Look at the third one. There is hardly any movement. There is no change in the dimensions of the chamber, and mitral valve is not at all moving, and there is no thickness change in the. So if you see this type of an image, you know very much, you'll be very much sure that this patient has got very poor LV, and you can plan your anesthetic technique accordingly. Okay. So to complete, so at this session, so you would have known how to get the parasternal long axis view and how to identify each structure in this view, as well as the parasternal short axis view and your subcostal apical 4-chamber as well as the apical 5-chamber view and the your subcostal. Okay, so in the next session we will be seeing what is the how do you do the diastolic function assessment, how to assess the right ventricle, how to identify the significant valvular lesion, especially the stenotic lesion, which are very important for the anesthetic management, and how to identify regional valve motion abnormalities. If time permits, we'll go and see the calculation of the stroke volume and how to use this. Most importantly, once you know all these things, then subsequently we'll see how to use this transthoracic echocardiogram during AFN for a patient who's hemodynamically unstable through different protocols, especially the 5E. With a lot of videos, I'll meet you in the next session. Thank you very much.
Thank you, Rajesh. Your astonishing presentation. Your videos are awesome, and your presentation and your explanation and teaching is more than that. So we are expecting more classes from you, sir, in the future. This is the beginning, I think.
Yes.
So we are expecting, eagerly waiting for your classes in the future also. So, Prasad sir, any questions?
No, sir. It was very enlightening talk, sir. Very nice one, sir. Slow, steady, as usual. You are very firm in your delivering the talk, sir. Thank you, Rajesh.
Thank you, Shiva.
Thank you, Rajesh, sir. It was wonderful. Very nice slides and very nice videos, sir. So informative.
We are really lucky to have you in our session, sir. Thank you. Thank you so much.
Thank you, sir. Thank you.
Further sessions also, sir.
I have to thank today's speakers, Dr. Prasad sir, Dr. Parthasarathi sir, and Dr. Rajesh. Thank you very much.
Thank you.
We will meet in the future also. So thank you, sir. Thank you, sir.
Thank you.
Shilpa, thank you. And I also thank today's Anaesthesia TV. First time they are streaming our presentation in the throughout worldwide. So I thank the Anaesthesia TV also. Thank you. Thank you so much. We will meet the next